Today I want to give a pretty high overview of ALS. So it'll be a kind of a fast moving agenda here because I'd like to cover a lot of territory if we can. Cover a little bit about the background and the history, epidemiology, some of kind of the usual clinical features of ALS, diagnosis, prognosis, and have a chance to describe the multidisciplinary clinic that we've developed here in the last year, which has really taken off, and talk to all of you about how that's set up and how that works. And at the end, I would like to cover three emerging, really interesting and I think promising areas within the field. So ALS dates back to Charcot is the father of neurology, and actually ALS is also referred to as Charcot's disease. He first described the disease in 1874. And Charcot, for those of you, many of you probably know, but he described clinically, did these very detailed clinical descriptions of patients, and then correlated those descriptions with pathology. He was also a pathologist. And this is actually a picture from one of the papers that was published back in the 1800s. The cord is upside down, but what they saw in autopsy in these patients were the anterior horn cells, there was drop-off, but also the corticospinal tracts showed these regions of sclerosis, and that is actually where the name comes from. The amyotrophy or muscle atrophy emanates from the drop-off of the anterior horn cells. So the origins of the name of ALS we can credit to Charcot. There are a number of people throughout history who have been afflicted with the disease, and I think that's part of the disease sort of has a lot of a legacy associated with it. There's a lot of history behind it. Many of the people in these pictures you probably know, but I didn't put the names up purposefully. It's still early, so I want to kind of engage you all. It's still just after 7. So this first individual was Chairman Mao actually had ALS, which is interesting. I don't think that was really well known and wasn't described till the end of his life, and was sort of hidden from public view. This individual here has already been mentioned, is Lou Gehrig, and I'm going to talk a little more about Lou Gehrig because he's probably the most famous person who was afflicted with ALS. You may not know who this is. Well, this is Jacob Javits, was a U.S. senator. Probably recognize, for those of you who watched a lot of TV in the 70s and 80s, David Niven actually had ALS. Charles Mingus, a jazz bassist. And another very notable person in history is Stephen Hawking. I'm going to talk a little bit about Stephen Hawking because his course was so different and has been so different than other people with ALS. And then Jim Catfish Hunter. We got a couple of baseball players here. I didn't realize that he had this until kind of preparing for this talk. And then you can see the name on the jersey here. Does anybody know who number 37 is there? Yes, I know somebody does because they came up to me. This is Steve Gleason. And Steve Gleason actually is more of a local celebrity. He grew up in Spokane. He played football for Washington State University, and then he played for the New Orleans Saints. And this is showing a very famous play where he blocked a punt in Super Bowl 40 that really kind of helped turn around the game, and it was really a big deal. Steve Gleason is still alive. He is intubated on a respirator and is a real champion of the disease, has started an enormous foundation for patients, and he's a real resource. When we need things for patients, we sometimes will turn to the Gleason Foundation. But a little more about Lou Gehrig, because Lou Gehrig's story is incredibly interesting. He played for the Yankees from 1923 till 1939, and he was referred to as the Iron Horse. And this is just an incredible statistic when you think about it. He played 2,130 consecutive games, which is just a staggering number. I don't even know how does somebody even show up to work that many days in a row. He played that many games, which is really just tremendous. He held the career Grand Slam record, the record for the most home runs for a first baseman until Mark McGwire. and he became the first player to bat more than 500 runs in 3 years. So he had this tremendous record, an incredible athlete. Lou Gehrig also played football for Columbia, and I'd read that he actually, I think in playing baseball, maybe in football too, he broke every single finger in both hands. So he saw a certain amount of trauma in his life, for sure, as an athlete. He was diagnosed with ALS at age 35, so pretty young, and 2 years later he died. He was diagnosed at the Mayo Clinic, so really tragic ending and a very rapid course to his disease. What's interesting, if you look at baseball statistics, you can see his amazing statistics here. You can see in these red columns shows the number of home runs that Lou Gehrig had each year since he played for the major leagues. And he was always up in the 30s or 40s until 1939 when he hit no home runs. And then you can see his batting average was always up in the 300s, and all of a sudden he fell in his last year down to 143. So clearly something was going on. So the disease bears his name because of his legacy, and many people aren't familiar with ALS, but if you say Lou Gehrig's disease, that will be more meaningful to them. Stephen Hawking is, again, I think a lot of questions come up with Stephen Hawking because he's lived so long with this disease, and how could this possibly be the same disease that someone like Lou Gehrig had, where he lived for 2 years, and Stephen Hawking is still alive with this disease? And there are some reasons for that. He was diagnosed shortly after his 21st birthday, and in juvenile or young onset disease, many times patients who obtain the disease at a young age, it has a variable course and it has a slower course. This in him has spared non-motor regions. There can be cognitive difficulties with ALS, and clearly this is not the case with Stephen Hawking. He's also had excellent care, and so he's still alive and has had just a different course than your typical patient with ALS. This is a graph from the PROACT database, which is a distribution of age of onset for patients with ALS. So this is thousands of patients that have been entered into this database. And you can see people develop this disease most typically in kind of their mid-50s to mid-60s would be the usual age. Other general facts about the disease: men are afflicted more often than females. The incidence is about 2 out of 100,000. And right now in the United States, there are 30,000 cases and about 5,000 new cases per year. The age of onset, as you guys saw, the age distribution, but average age is mid-50s, early 60s. Lifespan, if you go on the internet or go on the ALS Association website, what will be quoted is 2 to 5 years. And one point I'm going to try to make during this talk is the range of lifespan is highly variable. And there are a number of factors you can look at that where you can predict whether it's going to be a short or more prolonged course. Most cases are sporadic, but increasingly, they say now about 10% of ALS is inherited, and that number may be growing. The genetics of ALS has really expanded quite a bit. So a little more about the genetics. As I mentioned, about 10% of ALS is familial. It can be inherited via autosomal dominant, autosomal recessive, or X-linked. Right now, there are over 25 mutations that have been described, which is incredible. When you think about SOD1 was first described in '93, and now there's over 25 genetic mutations. And you can see here just the commercially available tests. There are a number of commercially available tests for ALS. What's interesting is in some of these families that have been studied, and in some cases of sporadic ALS, what's seen on PATH are these protein aggregates, and it's thought that maybe one of the clues is that there's misfolded proteins or something with protein processing that's going awry that's leading to degeneration of these neurons. If you have a patient who has family history, checking for all these genes would probably not be the best strategy. It'd be super expensive. You could do it, but as you can see from the percentages here, these top 4 really represent the majority of patients with familial ALS. So depending on the history, I usually start with checking the C9 mutation, which is the most common, And then if I wanted to do a little more complete, I may check the top 4. You're going to get about 70% of cases if you check the top 4 there. A little more about familial. As I've mentioned, about 10% of ALS is familial, and you have the breakdown and the various distributions of genetic causes for ALS in A here. But what's interesting is if you have the other 90% of sporadic ALS, and you kind of break that down and look at that other 90%, even without a family history, but you check them for genetic mutations, you still find a fairly significant percentage that are actually it's genetic. So the genetic causes to ALS is probably more than 10%. We're probably looking at 15%, and that number is increasing with time as more and more genes are being discovered. This is an incomplete graph. It kind of shows that back in '93, the SOD1 mutation was the first mutation to be described. And over the years, slowly but surely, more and more and more, and this is ending around 2014, 2015. If you go out to 2016, this curve is just going to shoot off top of the slide here with over 25 mutations now described. So there's a lot of discovery has been happening in the last several years. This really represents that. This is a poorly named website, Online Mendelian Inheritance in Man. I think they need to expand that to maybe humans, but that's the name of the site. It's a really great site, and if you go on the site and you put in a disease, you get all this information about every single mutation that has been associated with that disease. And this is for ALS, and you can see, I know the font's pretty small here, but practically every single chromosome has a gene that can result in ALS, and you can see all of the different mutations that have been described. This site is updated weekly, and so just shows that this is a really rapidly moving field, the genetics of ALS. One thing that's important is what kind of correlations can you make between the phenotype and the genotype? And I think it's important to state that if I have a patient in clinic and I don't know anything about their family history, there's no way to evaluate somebody and to know that they have familial or sporadic ALS. These are clinically indistinguishable. And even within one form of familial ALS, you can see a lot of phenotypic variability. For instance, the C9 open reading frame 72 mutation can result in ALS and FTD, or just FTD, and even some other things. So one mutation can cause a lot of different phenotypes. There are some limited correlations, and we know that there are some mutations that are associated with more lower motor neuron presentations, some with presentations that present in anatomic regions. I've followed a 3-generation family from Yakima that have this TDP43 mutation, and they all start in their arms. They all have initially arm onset weakness, and it's really striking when you see each member of that family. As I mentioned, C9 can present with various different phenotypes, and then some mutations are associated with rapid progression or slow progression. What are some other risks? What are some other environmental risks for ALS? And I've talked a little about heredity, age. It's always bad, it seems like, to be a male. So here, once again, for most diseases. But other known risk factors would be military service and exposure to pesticides. I want to talk a little bit about those two because that's kind of interesting. In the literature, there are many reports about head injury, and there are reports of increased prevalence of ALS in soccer players or football players. It's out there, but we still don't really know that that's a clear and known risk factor. A little bit more about the risk of having worked in the armed services. This is a study from 2016, but this was known before 2016, that if you ever were in a branch of the United States Armed Forces, doesn't matter what branch, it doesn't matter whether you were deployed, it doesn't matter whether you were in combat or had a desk job, you have a twofold increased risk of developing ALS. And no one really knows why that is. There's some common denominator there. I do know that if we ask all of our patients when we see them if they've ever served in the United States Armed Services, and if they have, this is a service-connected disability, and they're automatically eligible for benefits through the VA. So it's important to certainly ask people. The other thing that's interesting from this paper, and this has been a more recent discovery, is pesticides. And if you have a history of having worked with pesticides earlier in life, you have a 5-fold increased risk of developing ALS. I thought that was pretty dramatic. So probably more to come on that statistic and risk factor. I want to talk a little bit about the anatomy, because I think sometimes the presentation of ALS is very heterogeneous. And it's really helpful to understand where the disease is beginning and what is some of the anatomy behind that, so we can understand why people present differently. So for example, you have upper motor neuron system and a lower motor neuron system, bulbar as well as spinal. And if you have involvement of the lower motor neuron cranial nerve 12, or other cranial nerve involvement, this will typically present with bulbar ALS, or bulbar palsy. Opposite from that would be the upper motor neuron equivalent. So if the involvement is more from the corticobulbar tract coming down to the brainstem, supranuclear, that's referred to as pseudobulbar palsy. And these terms get really, I think, misused a lot in my experience. I see patients who've been diagnosed with pseudobulbar palsy and they have bulbar ALS, and so this gets confused. But there's lower motor neuron, upper motor neuron equivalents, and they present differently. Obviously, with the patient with the cranial nerve involvement, they get tongue atrophy, tongue fasciculations. Upper motor neuron, they get a spastic dysarthria, so it's a very different presentation. In the spine, if you have anterior horn cell involvement purely and no upper motor neuron involvement, you get progressive muscular atrophy. And some patients, their disease will just remain there, and that has a different clinical course. If you have involvement just of the or corticospinal tract, upper motor neuron, purely, that is called PLS, or primary lateral sclerosis. And ALS is where you really see all of this, but it may start in one place. It may start more lower or more upper, but eventually both systems are affected. The pathology I mentioned kind of showed earlier, you see involvement of the anterior horn cell and the corticospinal tract. If you look high power, you can see drop-off of anterior horn cells. And if you look under high power at an anterior horn cell, as I mentioned, often we will see these protein aggregations. And I'm going to talk a little more about why people develop these protein aggregations. TDP43 is one such aggregation that's seen in patients with ALS. A little more shift gears now and talk about the clinical presentation. The most common presentation would be weakness, fasciculations, cramps, dysarthria, dysphagia, and ultimately progressive respiratory failure, orthopnea. I see a lot of very nervous healthcare providers with fasciculations. And in the absence of weakness, it's almost always benign, but it freaks people out, because if they start having fasciculations and they go online, ALS pops up and they're like, oh my gosh, they diagnosed themselves. So I think Eric can probably share this, that we spend a lot of time kind of peeling people off the ceiling that no, this is not ALS. Yeah. Yeah, and so fasciculations, when you see them in isolation and you do not see weakness, it's almost always benign. It's almost always something else. But it gets people worried. If you see fasciculations with weakness, that's worrisome, clearly. It's not necessarily ALS, but it's a worrisome presentation. Now, we also see other things, though. And we see changes with behavior or language, manifestations of FTD, and often we'll see some emotional lability. And these are interesting aspects of the presentation that I want to talk more about. So on exam, we'll often see spasticity representing upper motor neuron involvement, spastic dysarthria, as I mentioned, hyperactive gag or jaw jerk, increased reflexes, and other manifestations really of spasticity. And likewise, in ALS, we'll see lower motor neuron involvement, so more of a flaccid dysarthria that could be associated with atrophy and fasciculations of the tongue, decreased muscle tone, hypoactive reflexes, muscle atrophy, and fasciculations are lower motor neuron manifestation. It's interesting, though, some patients will come in initially hyperreflexic, but as the disease affects more of the anterior horn cells, that will change, and they will then go from being hyperreflexic in a region to losing their reflexes as they lose that lower motor neuron population. So this can be a dynamic process. It is dynamic. This was a patient we had in clinic the other day, a patient of mine who had some fasciculation. I just want to show this clip really quickly. So here you can see this gentleman has fasciculations in his arm, not subtle, really large amplitude fasciculations that it's even moving his arm. They're so big. So I wanted to talk a little bit about why those fasciculations, they're such large amplitude. They're different, and the reason is as you lose anterior horn cells, the surviving motor neurons, as many as you know, sprout, and the motor unit becomes larger, and so the fasciculations therefore become much larger and obvious. So even on EMG, when we do EMG on patients with ALS, their fasciculations look bigger. They're broader, they're more complex, and clinically they can look different as well. One thing I'd like to mention is if you have a patient who, a lot of these patients have lost weight and they're thin and it's easy to see fasciculations, but in a heavier patient who has more adipose tissue, sometimes you can't see them, but you can feel fasciculations. So I'll often lay my hands on their arms or their legs to see if I can feel fasciculations if I can't see them. The disease has certain patterns I think are worth mentioning in terms of recognizing the presentation. I've talked about the upper and lower motor neuron pattern. On one end of the spectrum, if it's pure upper, you can see a presentation more like PLS. If the disease remains in the upper motor neuron system, that is PLS. You really can't make a diagnosis of PLS until somebody's had it for about 4 years if it's just remained in that region. PMA is pure lower. And then usually we see something along this spectrum in most ALS patients where they kind of begin in one domain and it spreads gradually across. The other pattern in patients is the region of onset, and ALS is a disease that generally starts focally, and so it can start in the bulbar region, it can start in the respiratory centers, it can start in the axial myotomes, and patients can present with head drop or axial weakness, or most classically it can present in the limb with arm or leg weakness. There was a really interesting study done by John Ravitz, who I worked with at Virginia Mason for about 15 years, and Dr. LaSpada, who was at the University of Washington. And they did this collaboration where they studied hundreds of patients with ALS and studied, just like Charcot, documented all the clinical history, how the disease progressed, and then looked pathologically at what they found. And there were some variables that they noted in patients with the disease. One was the region of onset, the mixture of upper and lower motor neuron, and then the rate of progression. And some of the takeaways from their study was first that the disease begins focally. It begins focally in the brain, and it begins focally in the spinal cord. It spreads contiguously. And this is a really important point, and you see this clinically, where the upper, it's a little easier when you examine patients with lower motor neuron deficits. If it begins, for instance, in a right hand, often we'll see it spread either to the right leg, a contiguous spinal region, or to the opposite hand. It'd be very unusual to go from a right hand to a left leg, just because anatomically those regions are far apart. And the progression is linear. And so a lot of patients want to know, well, how am I progressing? How am I doing? And there's some misconceptions. The disease doesn't all of a sudden take off and people progress super fast like some diseases can. It's linear. It moves at the same rate once somebody gets the disease. What's interesting about these observations is this is odd for a genetic presentation. This is much more indicative of more like an infectious presentation when you look at how this is anatomically spreading. So this has brought up some controversy in the disease. And I'll talk a little bit about a theory that might tie this to one of the newer theories. So red flags, just some pearls, red flags. If you see people in clinic with going from the obvious to maybe the not so obvious, tongue fasciculations, those are bad. I have not seen too many people with tongue fasciculations with anything other than ALS, but it can happen. That's obviously very concerning. Progressive weakness and generalized fasciculations, that's a very concerning history. Mixture of upper and lower motor neuron findings on exam. Progressive painless weakness. And I think for many of the surgeons, you guys are often seeing patients with weakness in an extremity. And they usually, most patients at some point have pain. They have that as part of their history. But progressive painless weakness is concerning. Dysarthria with progressive weakness, behavioral changes with progressive weakness, and then something called the split hand syndrome, which I don't know how many of you heard of this. So this has been described as almost a pathognomonic finding in ALS, where one half of the hand becomes atrophic. And so patients with ALS, we often see this in clinic, will lose muscle bulk in their first dorsal interosseous and their thenar eminence. So the lateral half of the hand is becoming atrophic, whereas ADM is relatively spared. And it's unlike any other pattern. You don't see that with an ulnar neuropathy. You don't see that with a C8 radiculopathy. You really just see that with ALS. And it's not really been known, but there have been studies that have speculated that this is probably because there's cortical involvement, and the cortical representation of the pincher grip is significant. And as that is lost, this distribution is how that is manifest. It's very interesting. So, and actually, this is a hand from one of my patients, and he has split hand. We see this in clinic all the time. Other system involvement, there can be a lot of very rare presentations with Parkinsonism, cerebellar involvement, extremely, extremely rare. I want to talk about FTD and Pseudobulbar Affect. FTD is characterized by progressive behavioral changes and frontal executive deficits and selective language deficits. It exists about 15% of the time in patients with ALS. It's frequently associated with the C9 mutation. I'm going to talk more about that mutation at the end. It's prevalent with bulbar ALS, and it is most commonly associated with behavioral variant FTD. ALS is most commonly and often with the psychotic symptoms. So if you look at the major variants of frontotemporal dementia, there are language variants, and then there is the behavioral variant, which is the one that we more commonly see in our patients with ALS. These patients can present with apathy, disinhibition, perseveration, executive dysfunction, disorganization, and importantly, very poor insight. And this can be kind of slow and insidious. And I think when in clinic, when we see patients, often I'll see somebody not in the exam room, they're outside the exam room, they're pacing in front of the door, and I think, oh boy, okay, this is somebody who may have FTD. Sometimes the behavior is subtle, and the family, it's so subtle and kind of insidious, may not fully recognize it, but once it gets going, it becomes more obvious. And I think our antenna is up in clinic for this, and families aren't necessarily aware that some of these behavioral changes are part of the disease. It's not just the patient reacting to the disease, it's part of the disease. We don't see the language variants nearly as often, and the behavioral variant is where you have bifrontal atrophy. Semantic dementia is more left intertemporal, and the non-fluent is inferior frontal and left temporal. I want to talk a little about pseudobulbar affect because it's also very interesting and something that sometimes you have to ask about, and patients and family members just they don't understand that, again, this can be part of the disease. I like this definition. Pseudobulbar affect is a syndrome of involuntary emotional expression dissociated from one's true emotional experience. So it's it's when somebody is crying or laughing, and they really don't necessarily want to be crying or laughing, but it is coming out in times that are sometimes inappropriate. It's pretty common. We see this in about half patients eventually with ALS, and it's very common in PLS because of the more upper motor neuron involvement. It is debilitating for people because as this really gets going, they can't go out in public. They find that they're crying at places they really shouldn't be, and they're laughing in situations that it's really not. It's not okay. So this is a clip. Looks like I'm loaded up here. This is a video of a patient who actually doesn't have ALS. He has MS, but he has Pseudobulbar Affect, and he gets into kind of a laughing spell, and you can get a sense of how he just can't really control this.
I'm okay.
He's just trying to suppress this really hard. So you can see this is, it's terrible, really. I mean, now laughter is a little bit contagious. The first few times I watched this, I'm starting to kind of laugh with him until you realize, this is pretty debilitating for this guy. Why does pseudobulbar affect, and it can be laughing or crying, and I've had patients in clinic where they're going from laughing and crying back and forth within seconds. So this can oscillate back and forth. It's very odd when you see that. So this is due to impaired corticopontocerebellar pathways. And this is I think this is one of the most eloquent studies. It was published in 2014. And this group looked at 25 patients with PLS and 22 with ALS. And they did DTI imaging, and they showed in patients with PLS and ALS, compared to controls, those without pseudobulbar affect, there was tract impairment in the pons, in the cerebellum, in the internal capsule, and the frontal cortex. And so it's the connection between frontal, which normally kind of controls our emotions, and cerebellum and pons, that you get this dysmetria, if you will, of emotional expression. So it's the emotional equivalent of motor dysmetria, where we sort of miss the target. Here we're missing the emotional target. So a very interesting study, and it really explains why this happens in our patients. A little bit on diagnosis, I do not test for all of these things. These are maybe some of the other diseases that I think about in patients with ALS. I do have a kind of a standard checklist that I look at when I see a patient who's been referred to me with ALS, and these are some of the things I'm thinking about and ruling out. I do a selective workup, though. If somebody comes in with tongue atrophy and tongue fasciculations, I don't send an anti-GM1 antibody looking for multifocal motor neuropathy. That just is ridiculous. So I really try to tailor it to, what the person's presentation is. EMG is very important, as I've mentioned. Fasciculations with pathologic waveforms, fibs and positive waves. If you see those together in 3 regions, that is very concerning, and that would meet EMG criteria for the disease. And MRI is also helpful mostly, and most of this actually is helpful to exclude other etiologies. You're really excluding. There's no, as you all know, there's no test for ALS. What's interesting is on MRI, sometimes if you window the MRI correctly or window it to look for this, you can see a high signal in the corticospinal tracts. And I've seen this in a number of our patients on MRI. A little bit on prognosis, because a lot of conversations with the patients we see in clinic relate to prognosis. The average life expectancy, as I've mentioned, is 2 to 5 years, but it varies greatly. And 50% of patients live greater than 3 years, 25% greater than 5, 10% greater than 10, 5% patients will live greater than 20 years. In general, life expectancy is dictated by the degree of respiratory impairment. Poor prognostic factors, again, being a man is bad. Age, of course, bulbar onset, respiratory onset are, for obvious reasons, poor prognostic factors. FTD, because many times these patients are just not compliant and can't really cooperate with some of the things we do that do extend their survival. There are some genetic mutations that have been associated with a poor prognosis. This was a really, it was a great study out of Italy in 2011, where this group looked at 1,300 patients with ALS, and they categorized the patients on their phenotype: upper motor neuron, lower motor neuron, bulbar onset, respiratory onset, and then they charted their clinical course here with different colors. This yellow line is the upper motor neuron group, as was the red. These are patients with just pretty much pure upper motor neuron, and they live a very long period of time. As you can see, we have like 70% of patients living at 10 years. When you have upper motor neuron involvement, you're not denervating your diaphragm, so you can live a lot longer with pure upper motor neuron involvement. Respiratory onset, I don't know if you can see, but that gray line is respiratory. So their prognosis is quite poor. So I find this helpful if I see patients with more of an upper motor neuron phenotype. I can kind of reassure them this pattern tends to portend a better prognosis. And likewise, if I have patients with bulbar or respiratory onset, we come to terms with this is going to be a more aggressive course. Now, I want to talk about the clinic here. Our goals in clinic are to improve quality of life, develop treatment, advance understanding of the disease, improve function and preserve independence, support the patient and their family, and end-of-life care. And there are a number of challenges in these patients listed here. And initially things are slow, but as the disability accumulates, everything is going wrong. And I can't imagine being in solo practice trying to manage a patient with ALS. It would be pretty challenging. So we have a team of people who help address all of these different things and are experts to help our patients with all of these different problems. The American Academy of Neurology has a list of quality measures, sort of expectations of what should happen in a multidisciplinary clinic, and we do all of these things in clinic. We put people on disease-modifying therapy. The only therapy right now is Riluzole. We screen their cognitive function. We treat symptoms of sialorrhea, cramps, pain. Three areas I want to focus on that I probably spend more time in clinic addressing relate to breathing. And so timing of BiPAP is very important and is one of probably the most important thing we do that extends survival in these patients. So if their forced vital capacity, and we measure their breathing every single time they come in clinic, if their forced vital capacity is less than 50% or their MIP, inspiratory pressure, is greater than 60, dropping at that level, they qualify for BiPAP, and then we get these patients started on BiPAP. A staggering statistic is that the median survival benefit is 205 days if you get people on BiPAP. So it's a very important intervention. And in addition, people don't really totally understand why. It's been shown that it actually slows disease progression, sort of supporting that diaphragm. And it improves quality of life, sleep, etc. The other big timing piece is when should patients have a feeding tube placed. And in general, we try to have a feeding tube placed before patients' forced vital capacity is less than 50%. After that, it gets a little harder to do it safely. So we encourage people to have it done, and it's just better tolerated when their forced vital capacity is over 50%. Or if they have severe dysphagia, we encourage having feeding tube placed. We have it done through interventional radiology and have a low-profile feeding tube placed so they don't have this feeding tube kind of hanging out on their abdomen. And we do quite a bit with hospice, and some of the patients, we have conversations related to death with dignity in this state. This is a list of our team, and there are a number of people from the team here, and I feel extremely fortunate that no sooner did I get to Swedish, we had just all these people come together, and so we have all these different disciplines that are in the clinic, and I feel extremely fortunate because this is the group that's really doing all the work and taking care of these patients. I want to show you a little bit about how the clinic works. And so we have 4 patients show up all at once. They get roomed in 4 different rooms, patients 1, 2, 3, 4. And then the various team members come together as a group. So I come together with the nurse, the respiratory therapist, the speech therapist, and the dietitian, because they overlap a lot, meet with another patient. We have physical medicine, PT, and OT, because they share a lot, meet with a different patient. And then palliative care, social work, and the ALS Association comes to every clinic, meets with another patient. And we spend about 45 minutes with each patient, and then we rotate. That's the extent of my animation that I can do on here. But it's really great. So we can see kind of when one group moves in and out, and from a multidisciplinary approach, I mean, it's a scheduling nightmare, right, Denise? But it's really great. So as the people come through clinic after 3 hours, they've seen 11 providers, and we have really, I think, often I'll go in with the last patient and I say, "Do you have any questions?" And they're like, "No." We've really covered everything, and it's great to have people like a dietitian who can really advise them about that. Whereas I don't have that expertise. In the rooms, we have a communication board where we list what are their concerns. We write down their pulmonary function. We do an ALS FRS in every single clinic. And we're going to be increasing our throughput. The clinic is full, so we're going to be expanding this and increasing so we can increase our volume. The other things that we do is the day before, 1 or 2 days before, our nurse will call the patient. She completes an ALS FRS rating scale. She gives us a summary. So I walk into the room and I know what's been going on with that patient for the last 3 months, which is fantastic. They see the 11 providers in clinic. Afterwards, we mail them a written summary or we send it electronically. So they don't have to be in there, writing notes or keeping track of every single thing we're telling them. And the nice thing about the ALS Association is they can have a representative go to the patient's home. Sometimes stuff's happening in the home that can inform us on how to best care for that patient. We typically see people every 3 months, and then we're increasingly developing a number of clinical trials to offer people in clinic. I want to end, though, with, yeah.
So that clinic sounds spectacular, but it sounds like there's a lot of moving parts there.
Yeah.
You do that every week?
We do it every week. Yeah.
And the ALS patients, they already know their diagnosis before they go in.
Right. That's a good point. And so I see, or the neurologists will see and make sure the diagnosis is clear, have that conversation, and then we refer them into that clinic.
This has many applications for other kinds of neurological.
It does.
Menu for that.
Oh, thank you. Yeah.
I think that's really.
Yeah, I'd like to see, it's a great model, and maybe it doesn't have to be as big, but we could do this on a smaller scale in with a lot of other diseases.
Yeah, it's visionary. I mean, there's some things that we can do at least in research.
Cool. Yeah. 3 really interesting areas that I wanted to share with you all before we end. HERV-K, C9, and stem cell therapy. This is one of the more recent and I think is one of the most interesting stories. Human endogenous retrovirus K. I had never heard of endogenous retroviruses until I started reading about this. But the idea is that we all harbor retroviruses, endogenous retroviruses, in our genome. They're silent. And before I talk about the theory of HERV-K, I want to just, by way of review, talk briefly about retrovirus. So retroviruses bind to the cytoplasm. There's reverse transcriptase that ultimately the DNA is shuttled into the nucleus, and the DNA is then incorporated into the host DNA. The host DNA then undergoes a transcription of the viral genome. That is transported out into the cytoplasm, where translation sends the proteins, but also the RNA that goes back into the virus, and then this continues again and again. The interesting thing about HERV-K is, or HERV, human endogenous retroviruses, is that about 8% of the human genome contains these retroviruses. And these are remnants of infections that we have all been exposed to over millions and millions of years. And so it's sitting there, and it's not really been known what this was doing, or if anything. This happens because there's an integration of a provirus into the genome of DNA of germline cells. So this can be passed on from generation to generation. HERVs can be expressed under pathologic circumstances, and HERV-K expression has been implicated in neurodegeneration and ALS. So this was a study which was just recently published, September of 2015, and you can see here's the HERV-K genome sitting in our DNA. And what this study showed, they looked at 11 patients with ALS and 15 controls who all had Alzheimer's disease. And they found that in all the ALS patients, there were increased transcripts of the 3 HERV-K genes in all of the ALS groups, but not in the controls. They're very interesting. They then went on to do a number of studies, including immunostained brain and spine from patients with ALS, and they found increased expression of the envelope protein, which is one protein component of HERV-K. They found that in the cortical neurons of ALS patients and in the anterior horn cells. That looks pretty concerning that this is something that's potentially relevant to ALS. So the whole study, in addition to showing the expression, they went on to do in vitro studies that showed that HERV-K in human neurons in vitro causes neurotoxicity. Expression of HERV-K envelope in vivo caused degeneration of motor neurons, and that they then had a mouse model where HERV-K envelope protein was expressed in transgenic mice, and they developed an ALS-like disease. So really fascinating, and there is even more recent information. Dr. Nath has been the one from the NIH who's spearheading this, and he described HIV-associated motor neuron disease with the presence of HERV-K, and this was September of 2016. What he reported was 5 patients who had HIV who later developed an ALS-like illness. And this has been reported in the literature, and it's one of the reasons you test for HIV in patients who have ALS. And what's interesting, in these 5 patients, they had elevated HERV-K levels. And so Dr. Nath went on to treat these 5 patients with antiretroviral therapy, and 3 of the patients had complete reversal of symptoms, got better, and 2 had a much more protracted course, and it slowed the progression of their disease. So this raises a question of, again, there's been speculations about infection. No infectious entity has ever been implicated in ALS, but remember that model I was showing you about spread, which has been hard to explain on many levels, but when you think about this mechanism, that might explain that spread that Rabbits described in his studies a few years ago. A little bit about C9. This is also fairly recent discovery. C9 open reading frame 72 is the most common genetic cause of familial ALS. It is a hexanucleotide repeat, and there were 2 groups, one from the NIH and one from Jacksonville, Mayo Clinic Jacksonville, that pretty much simultaneously reported this, and in the same issue of Neuron reported this finding. C9 open reading frame 72 ALS can present with ALS, ALS FTD, or frontotemporal dementia by itself. It often, in the ALS patients, presents with bulbar onset. In the FTD patients, it's behavioral variant. It can present with this wide range of phenotypes. In addition to those, there's other manifestations. What is really also fascinating with this mutation is that it varies by geography. So in northern England, 43% of familial ALS is due to C9 and 7% of sporadic. But in Finland, 61% of familial ALS is due to C9. So because of this geography effect, as you get further away from Scandinavia, it gets more diluted. This is suggestive that there may have been a common founder many years ago in Scandinavia. We really don't know, but that's what this may suggest. C9 is passed on autosomal dominant. It is prevalent, penetrance rather, is 0 if you're under 35, 50% by age 58, and 100% by age 80. So this is another reason this gets passed on, is during reproductive years, you're not affected. So you can just pass this on to your offspring, but as you get older, you get affected. Again, it's a hexanucleotide repeat. And there doesn't appear to be a relationship between expansion size and disease severity. This is just showing the repeat here, and if there are over 30 repeats, this is pathologic. What's been shown in C9 is, again, these protein aggregates, once again, but in this model, I think we have a better understanding about why people get protein aggregates, which is really fascinating. This study just shows that C9 is in normal individuals, but not expanded. So you can have the mutation in normal individuals with less than 30 repeats and in multiple tissues. If you have expansion, you most commonly will manifest with ALS or FTD, but you can have other presentations. And I think, Rosa, you mentioned that the last time I gave a talk on ALS that Huntington's can present with this as well. Why the protein aggregates? And this is very recent, September 2015. There was a paper published that shows normally there's protein processing between the nucleus and the cytoplasm. So normally proteins in the nucleus are shuttled out into the cytoplasm, and then these proteins are brought out of the cytoplasm and back into the nucleus for just the mechanics and health of the cell. When you have this hexanucleotide repeat, the messenger mRNA itself, as it's being transported, it's thought from studies, comes in and disrupts this nuclear pore. If it gets to the cytoplasm and undergoes transcription, a dipeptide repeat is made, and it's also thought that is toxic and disrupts the nuclear pore. So what happens is proteins now can't get back in. They get stuck. And that is toxic to the cell, and the cell dies. And that's why we're seeing protein aggregates in the cytoplasm of patients with ALS. So this has been really interesting. It's been kind of the first theory that has finally kind of explained what's been seen on PATH. And the hope is that antisense therapy can be used to block that hexanucleotide repeat, prevent progression of this disease. So that represents promise for future treatment in these patients. So at the very end of the talk here, I wanted to just touch on stem cell therapy. Stem cells are undifferentiated cells that are capable of giving rise to infinitely more cells of the same type. In treatment, there's two main cell types used in treatment: embryonic stem cells from embryos less than a week old, or mesenchymal stem cells, or adult. Mesenchymal stem cells are harvested from bone marrow, blood, or adipose tissue, and they are generally injected into the same host, so they are autologous. Embryonic stem cells, not being autologous, require immunosuppression if they're used, but mesenchymal stem cells do not. Neural stem cells differentiate into various neural tissue. How does stem cell therapy work? And there's a lot of misconceptions from patients for sure that people think you inject the stem cell and it turns into a motor neuron and it grows an axon, it innervates the muscle, and people get better. That does not happen. There's no way for that to happen. So a lot of misconceptions and beliefs around that. But what the theory is that if you can get stem cells in the vicinity of motor neurons and they can release neurotrophic factors, you may be able to help an ailing anterior horn cell live longer and undergo the stresses of the disease and make an impact on the course of the disease. So you can inject stem cells directly into the spine. You can inject them intrathecally. Intramuscular is proving not to work so well, and systemic as well not work. But you can also induce stem cells to release neurotrophic factors. And this is just a slide showing how stem cells are harvested from adipose tissue, cultured, are then processed and engineered in a way that they can release neurotrophic factors, injected into the intrathecal space, and then can, once there, release neurotrophic factors to help ailing anterior horn cells. And this was from an Israeli study recently published in March of 2016, where they injected intrathecal mesenchymal stem cells that secreted neurotrophic factor. So only 6 patients, and patients had a certain decline in their functional rating scale. They got the injection, and then they show that there may be a hint of a change in the slope of that curve. This is not a controlled study. It's 6 patients wouldn't really conclude anything from this. This was a phase 1 study that says that this can be done and it can be done safely. Intraspinal injections, and I believe Eva Feldman gave a presentation here about a year ago. This is trickier business where there is Eva Feldman's group has this gondola that travels up and down on these rails on the back of the spine, and then there's this Z drive that sits on top. A cannula is lowered down over the surface of the spinal cord, and then the cannula is a needle is inserted, and as this is retracted, there's this flexible tubing that's attached to the needle such that if the patient's having cardiopulmonary movement, that the needle is not disrupted and it doesn't injure the spinal cord. It's a very, very clever device. And actually what they showed is that they could do this safely, it didn't injure the cord, and phase 1 study was successful. There were some complications, but they were relatively minor. So phase 2 studies have been performed, and they have not yet been published. So we don't really know the efficacy of this yet, but studies are ongoing. So in summary, ALS is a complex disorder affecting the motor system, has significant phenotypic variability. There's likely both genetic and environmental causes. Care of these patients is best accomplished by a team, and I'm very thankful for the team we have here. And I think future therapies will either be very, very targeted, like antisense therapy, or very broad, like stem cell therapy, that just doesn't matter what the cause; they have a broader effect. So that's all I have. Thank you.